So I have the pleasure of introducing our next speaker, Lisa Beth Paradise. She is a palliative care nurse practitioner who started the palliative care program at Poudre Valley Hospital, and now we're a group of 9, so we have a lot to be thankful for in Lisa Beth. She has a lot of experience in palliative care and worked up in Anchorage, Alaska, and I have the pleasure of sharing an office with her, so I will let Lisa Beth take over. Thank you.
Thanks, everybody, for being here. Public speaking is not my best talent, so please bear with me and humor me by looking friendly out there. Super happy to see everybody here. As Peggy said, I came from Anchorage, where we were a most state, and most forms, just like Dr. Jackson shared, are much more enculturated in that part of the country. So it was very normal and natural when you're meeting with patients that had serious or chronic illness to have a nice discussion and then capture it on this document that really helped ensure that patients were getting the type of care that they were looking for, essentially. So it's my hope, our program's about 4 years old now, that I'm seeing a change, a shift, a tilt in our community, that this document can actually be an incredibly helpful working document for some of our most frail and vulnerable in the community. So I was asked to just reiterate when we're talking about decision-making capacity that Peggy thankfully pointed out that capacity is much different than competency. We would never ask any of you to evaluate competency because that is a legal term. But what happens when you meet with somebody and they don't quite understand what's going on with them, they don't quite see the picture, their full medical picture, and again, capacity is time sensitive. So you meet with them, at one point and they really seem to understand it, but you meet with them and you're going to have a more robust conversation and they really don't. So what happens then is that you really need to ensure that their medical decision maker is available. And if they don't have a legally appointed medical decision maker, which would be a medical durable power of attorney, then our state actually was ahead of the curve about 20 some odd years ago. We're not a default state, which means if you do not have capacity, a medical provider doesn't necessarily just default to your spouse or your parents or your siblings or your children. We were actually ahead of the curve for same-sex partners, so that basically anyone with an interest in you as the person could step forward and say, I know and love this person and I feel like I could speak for him or her. And so we have this crazy, sort of old now, hierarchy that is essentially what we call a proxy. So if someone has not filled out a medical durable power of attorney form when they had capacity and could say, I want my daughter to speak for me, and you assess them and they really don't have a good grasp on what's going on with them, then we need to move forward with what's called a proxy form. If they regain the ability to speak for themselves and to orally appoint who they want, it is ideal to get that medical durable power of attorney done. A proxy is the next best thing. But then you would be gathering either that medical durable power of attorney or that proxy decision maker and having the conversation with that person instead of with the patient who does not have capacity. So that hopefully that covered what Jill asked me to cover. I think it was Jill. All right, so starting the most form conversation. And like Dr. Jackson, I pretty much have this conversation every day. And it is a conversation. It is a stepwise approach. And I'm going to try not to stray too far from the script here by giving you anecdotes of what I do every day, but I'm pretty impassioned about how valuable the form can be and how useful it can be. So in healthcare, as Peggy said, I don't think that we do a very good job talking or preparing for not the if, but the when we reach that last chapter of life. And I think there's an incredible opportunity here to do it well by helping people ensure that we're matching medical care with what things they value, what things are important to them. So it really does start with a value-based conversation. So going in and kind of laying the foundation with people that you want to have a conversation about stuff that's kind of hard to talk about, and giving them some resources, not straight off the bat, but after you're together for a while about, this booklet, you guys can continue this conversation, can be really helpful, and then going back in and documenting those preferences on a most form after you've had a lot of conversation. So I usually give a warning shot to people. I want to talk to you about something that's not always easy to talk about, and that actually gives the power to the patient and their family. And I can't emphasize how important it is to have family members privy to this conversation, because that's where on my end I see a lot of disconnect when I have chronically ill patients come into the hospital and they have preferences documented in a MOS form, and I call the decision maker that's listed, and number one, either they're not really the decision maker, it says medical durable power of attorney on there, but they're not, or they've never heard that this conversation took place. It really sets up a difficult conversation with that person, the family member. It kind of breaks down some trust about what the medical community wants or has in terms of goals for their loved one. And so really having the most important people there for the conversation is incredibly important. And it really does start with, as Dr. Jackson says, I want to talk about some things that are kind of hard to talk about today. Can you tell me kind of a little bit about what you understand is going on with you, going on with your health? And it give the patient and their family some time to reflect back on what's going on with them. Not only does this help the family sort of verbalize out loud that they see their loved one's medical condition changing over time, but it helps the patient to be able to sort of lay out, yes, I think things are changing for me. My breathing is getting worse. It's harder for me to get to the bathroom. It really gives an opportunity to lay a foundation so that you can know exactly where you stand as you start to talk about the more serious sort of topics that we talk about on the MOST form. So it really starts with, have you ever given any thought to what things are most important to you right now? What gets you up out of bed? What brings you joy? That's a value-based series of questions. And what is your understanding of, what's going on with you and your health right now? Keep it simple. That's another bit of advice. We tend to get into medical jargon when we feel uncomfortable, and I think keeping it very simple is very helpful. So again, I usually ask people, what things bring you joy, what things are most important to you, because then that helps you when you get to the meat of the MOST form in saying, you've told me that being able to get up and go to the dining room with your 3 best friends, that you've done this for the last 5 years, is the most important. What would it be like if you were unable to do that? And the patient can usually tell you that would be unacceptable, or that would be okay if they could come to me. They're going to give you some information to work with there, which can again help you when you get to, let's talk about medical care as you get sicker, because a lot of times medical care as you get sicker takes you away from things that bring you joy, even if that thing that brings you joy is going to the dining room with your best pals at the skilled nursing facility, for example. And spending your time listening is another key, and that's hard because I know that there are usually time constraints around this, and I guess I definitely have the luxury of having a little less of time constraints and more of the ability to really understand that this is a stepwise approach. So I try to develop some rapport with the patient and their families about what things make them tick, what they're most worried about, and what they're most hoping for, and then planting the seeds of, you have an incredible opportunity to help us prepare for medical care as your condition changes. It keeps the control with the patient, really, and I try to set that up because most people, as they're losing ground physically, they really need to have as much control over things that they can still have control over. And so being able to plan for the inevitable and setting that up and then documenting that in a way that we can respect them on this medical form is very empowering. So when we, some of the things that we say, where would you want or not want to receive care? I usually ask, have you ever given any thought to where you'd like to be at the end of your days? Very, very simple question. A lot of people have, but nobody's elicited that information for them. Again, it can help us when we get to the filling out the form. I do not have the form out, by the way. It is not out. We are having a conversation. My biggest piece of advice is that green form should not be around when you're having this conversation. You might set it up that, at the end of this, I'd like to be able to capture this on this form, but you're just having a conversation. I noticed that you've been coming in and out of the hospital a lot. I've seen you come back from the nursing home 3 times this month. How is that for you? If you ask that question, I can't overemphasize how many times people say, this has been really hard. Or if I'm talking to a medical power of attorney, someone's decision maker, because the patient can't really navigate this conversation, the family will say, I just don't know if this is the right thing now. And unless you crack that door open to say, how is this experience for you, people will tell me often, I felt really guilty about saying, I'm not sure this is the right thing. I felt like you guys are offering to do all of this care every time my mom comes into the hospital. It felt really weird for me to say, maybe this isn't the right thing. So I think it's important to say, are we doing the right thing for your mom right now? I noticed she's had a really hard time over the last couple of months. We've seen her quite a bit here in the hospital. I just want to make sure that we're doing the right thing for her at this point in her life. Quality of life. Ooh, boy, I'm just going to speak from the hospital side of things. We are really opinionated about what other people's quality of life is. And that's a big no-no, because somebody who's been wheelchair bound for 50 years and who has very limited mobility and very limited world, maybe their world is very small, may have a tremendously good quality of life. We don't know that, and it's not our onus to say, boy, their quality of life really stinks. So having patients define what is quality for them is important. What gets you out of bed, what brings you joy, how are you doing in general, and open-ended questions so that they can give you the information you need, so that when we start talking about aggressive medical interventions, do they match what you've told me gets you up out of bed in the morning, brings you joy, brings you your life meaning. Decision tools. So we do hand out a lot of decision tools, and I think the Conversation Project book is really helpful. I know that there are lots of references in your packet. I don't know all what's in there, but I will talk a little bit about 2 decision tools when we get to the CPR, when I talk about CPR with people that I hand out. The Conversation Project, if we sit down and we have the beginnings of this type of conversation, and I say, I'm going to come back and check on you tomorrow, but I have this booklet that really helps you two continue this conversation. And I think it would be really helpful for you to try and it's not mandatory, but to try and work through the workbook so that your daughter can really hear what things are important to you at this point in your life. And people like this, they really do. Handouts are incredibly important to sort of augment what you tell people. And it's also important when we hand people forms to assess their ability to read the forms. And we've had a lot of people get handed information, and I just sort of have a sense of, how well do you read? How is it, can you see the print? Is this an okay form to share information with you? Because I think we skip that part a lot. Again, I'm going to try to stay on the slide task, but I'm just kind of going to walk you through when I do a most form. What is your understanding of CPR? I really start out with firing a warning shot. I want to talk to you about some hard things. I get called in a lot to talk just generally about code status with patients and families. So CPR, I talk about what is your understanding of CPR. I use words, I think probably Dr. Jackson and I are very blunt in our verbiage. I say CPR is a medical intervention that we start when you've died. You do not have a pulse and you are no longer breathing. The alternative to attempts at CPR is to allow a natural death when that time comes. It's so important to say what we will do, okay? So CPR essentially is, people think that it's miraculous. University of Chicago did a study that said that on television and movies, CPR is portrayed 85% of the time as being successful, when in reality, the majority of us have a 20% chance of being successfully revived from CPR, and the patients that we work with multiple comorbidities actually have a 2 to 3% chance of being successfully revived. It was never intended to reverse death at end of life from chronic or serious illness. It was intended to reverse death from one type of heart arrhythmia, and we found it was incredibly helpful for things like electrocution or near drown when your heart stops. It was never intended to reverse death for our chronically frail and elderly patients. And I usually give my recommendation that it will likely prolong suffering in your mom, in you, because the cause of your death is your underlying heart disease. The cause of your death will be your underlying cancer. And I think it's important for people to know that. And if at the end of my conversation they choose attempts at resuscitation, then they've made a more informed decision. When we talk about the full limit, or full selective and comfort-focused measures, essentially I delineate the full and selected between being on a ventilator and not. And most of my patients, when I'm talking to them, are not on a ventilator, so I can say, right now we're doing selective medical interventions, which means we are using all efforts to reverse your acute situation while trying not to go toward the artificial respirator, the breathing machine. Have you ever been on a breathing machine? What was that experience like for you? Would you ever want to go back on a breathing machine? There are some patients who do very well on a breathing machine. You know, the little COPD or who's been on the vent a few times, who comes in with a pneumonia and gets off the vent, and I describe to people that being on the ventilator is a bridge. And if we're worried that you get on that bridge and we're not going to be able to get you off, I need you to be able to talk to your family about the what ifs and the whens and what might that look like for them. People have no idea really what it's like what it even looks like to be on a ventilator. When I describe that you wouldn't be able to talk, that you won't be able to eat, that you won't be able to interact with your family, they go, what? And so again, I think it's really important to talk about the difference between full treatment and selective treatment. Is selective treatment, we're going to avoid that machine, but we're going to do all efforts to get you back to your baseline. If you develop breathing problems, these are the things we're going to do to help you. We're going to give you medications for your shortness of breath. We're going to make sure you have oxygen. We can sometimes use the mask, but we would not put that tube down your throat because I worry that with your underlying cancer, heart disease, lung disease, liver disease, that we wouldn't be able to get you off that. And I also think it's important that we give recommendations if you're in the position as a provider of any kind to say what you think as a medical intervention would be helpful or not helpful. And that's where you come in terms of calling somebody's primary care provider to say, hey, you've taken care of Gladys, we're having an advanced care planning conversation. Do you think attempts at CPR would be helpful for her? Do you think being on a ventilator would be helpful for her? Do you think artificial nutrition would be helpful for her at this stage in her life? And then you bring that back to the family because it helps to show coordination in terms of giving appropriate and beneficial care to your patients. Okay, so how well does CPR work? I think I addressed this. This is a great handout, and I do believe it's in your packet. It's from a Canadian organization. It's called Speak Up, and it's nice because it actually is visual. And we also use the handout quite often from the Colorado Advanced Directives Consortium, which Peggy mentioned. There's probably some things in your packet from there, and it's an amazing website. It has the frequently asked questions for the most form, but it also has a wonderful handout about CPR. And I almost always give out that handout to families after I talk with them about CPR. And I really think avoiding the do you want CPR or not is the biggest message that I can send, because CPR is an incredibly violent and ineffective medical intervention for most people at the end of their days. So if we're looking at chronic and frail elderly people, it's not a medical intervention that's highly recommended at all. So these handouts can be really helpful. I usually say, we've had a lot of hard discussions today, and I'm going to leave you with this handout. This has a lot of the facts that we talked about CPR. And again, I have the luxury of a little bit of time to be able to go back the next day and say, whew, that was some heavy stuff. What are you guys thinking? But most of the time when we get through a conversation, people are able to say, that doesn't sound like that's going to help me. This sounds like this, I would still want to try this. They kind of have a more clear view of what they would want or wouldn't want. Outcomes for CPR survivors, we talked about briefly. About a quarter of the people will go home independently. Another quarter will go home but will require help. The biggest issue that we have with CPR really is that after about 4 minutes, we start to lose oxygenation to the brain, and if you're already chronically ill, we do break ribs if we're doing it correctly. It was never meant to reverse death at end of life. That's really the basic message about CPR, that being successful means that your heart is beating. It doesn't mean that you are the person that can still go to the dining room or interact with your friends at your assisted living facility. And I went way ahead to medical interventions, so I'm going to kind of back up a little tiny bit, and there's going to be opportunity for questions at the end. But when I talk to people about full treatment, I'm talking to them about being on the ventilator, being in the intensive care unit, having all efforts made to medically prolong life at any cost. And those are usually the words that I use. Selective treatment, typically the patients that I see are in the hospital and they're getting selective treatment. So they're getting selective treatment typically by default. They haven't gotten sick enough to get to the ICU yet. And we are being pretty aggressive with things like oxygen and antibiotics and fluids, et cetera, to help somebody get back to their baseline. And then comfort-focused treatment really is reserved for when patients and families tell me that, I have been in the hospital 3 times this month and it's getting really hard and I'm not sure I want to come back. And on my end, as a palliative medicine provider, my continuum of care says that at that point, if people are really expressing that they really don't know that they want to come back to the hospital, it is my duty and my precedence to talk about the next very important step in the care trajectory, which is the help of hospice support. That is the natural continuum of palliative medicine. And I bring that up as support to enable a person to remain in their home environment, wherever that may be, with the most robust assistance to not only the patient, but their family and their caregivers. And so most of the time when patients are checking, or we're checking a comfort-focused box, I'm really trying to include all the team players that I can ensure to help that patient meet their goal of not returning to the hospital. And I often find that without the support of hospice, we kind of have this panic mode that even though the box says comfort-focused treatment, if somebody has a new fever, unresponsive, you name it, something dramatically has changed, that they end up coming back to the hospital, which wasn't their goal when we were talking about goals and values. And so, from the palliative medicine world, our trajectory is how do we get hospice involved to sort of have this extra layer of support. I describe that to families as the ICU level of care for your mom at this time. Artificial hydration and nutrition. This is probably the trickiest thing to talk about with patients and families, and that's what I say. I want to talk to you about something that's this is the hardest thing that I talk about. And I talk about you've just described to me that your mom has had a really hard trajectory the last 3 or 4 weeks. Things have been really changing for her. You've been describing to me, Mrs. Jones, that your appetite is just so awful. And the daughter will chime up, yep, and I've been trying to get her to eat, and I've been getting her protein shakes, and I've been doing this, that, and the other thing. And so it's a perfect opportunity to talk about, have you ever experienced anyone else getting frail or sick? And it's amazing how many people say no. It's truly amazing, and that's a great opportunity to educate people. That in my experience, I meet a lot of people who really have never navigated this before. And what I want to share with you is that, Mrs. Jones, what you're telling your daughter about not feeling hungry and really not having the oomph to eat is really normal and natural. And I want to tell you, as the daughter who loves your mom and wants her to get better, that that's a really hard thing to hear. And so we often jump to, how can we artificially feed Mrs. Jones to make her feel better? And what I want to tell you is that there really haven't been any studies that show that artificial feeding enhance quality of life. Now, there are times when artificial feeding can be incredibly helpful. The patient who's had a stroke, in a region of the brain where their swallowing has been affected, and we have a good indication that with time that we might be able to work on that. It's a bridge. It can be a bridge to getting better. But for the person who has the dwindles, who their intake is going down, we have to normalize that, and we have to tell people that that's a normal part of entering into that last chapter, however long it is, of life. And we need to sort of give the patient permission to continue to say, I'm not really hungry. And we need to give the family members tools to know that it's okay to back off, but you also need to recognize that eating and feeding people is part of who we are as a culture. And when mom gets sick, or when we were sick as children, what did we do? We feed each other. It's part of how we nurture. So really talking about the benefits and burdens of artificial feeding is incredibly important because it's hard to undo. This is something that of all the medical interventions that we do, when we insert, so this is how I talk about feeding tubes. Would you ever endorse having a feeding tube surgically placed through your belly into your stomach? And man, people's opinion about feeding tubes are really strong. They're either, yes, I want that, but most are, no, 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 I don't want that. And so you have to assure them that we are going to do everything we can to try and keep your appetite up and offer you food and water, but we're not going to insert that tube long-term into your belly. That's how I talk about the feeding tube in the most form. What are your thoughts? How is your appetite? Normalizing it for the family. I just sort of really put it out there that when we're going through the most form, this is the section that kind of gives everybody the most heartburn. It's really hard. And that's what I say to them. And I say to them, let's talk about what food and fluid means to you as your mom's health has changed. And we talk about what's normal, how it makes us feel, and we normalize it. And we assure people that at the end of the day, your mom is not going to die because she's not eating and drinking. She's not eating and drinking because I'm concerned that she's starting the dying process. So normalizing it and then assuring them that if you thought that, me as a provider, I can say this, if I thought that that artificial feeding would help your mom to meet her goals that we talked about earlier, I would recommend it. But my worry is it's simply going to cause increase in her work of breathing, increased symptom burden, essentially anything that related to that particular patient that by starting artificial feeding may cause adverse reactions. Because I've talked a lot about adverse reactions informally. Adverse reactions of CPR are broken ribs, anoxia, the inability to really come around to the person that they once were. There are adverse risks to artificial feeding, and most people really have this connection with nurturing and eating and worrying that their loved one without it is going to suffer in some way. So now I am wrapped up.